I'm Anissa Mitchell with PMD Alliance, and today we are going to be doing a deep dive into MSA, otherwise known as multiple system atrophy. I know there are people out there that have heard this MSA word term thrown around and wasn't really quite sure what it is or how that relates to Parkinson's disease. So we're going to be addressing some of that information for you today. And we have an expert in the field for this with us, Dr. Nikolaus McFarland. He is a movement disorder specialist at the Norman Fixel Institute for Neurologic Diseases. I keep wanting to call it SHANS because that's what it used to be called. Is also Associate Professor of Neurology in the Movement Disorders Division of the University of Florida's College of Medicine. He directs the Comprehensive Multidisciplinary Clinical Research Program for Atypical Parkinson's and a clinic. His research is focused on identifying and ways to develop novel therapeutics for Parkinson's disease and related disorders, and is actively involved in multiple clinical trials for atypical Parkinsonisms and Huntington's disease, which I'm hoping to hear a little bit about today. So I probably miss some other key important things about your background, Dr. McFarland. So I'm going to hand this over to you and let you take it from there.
Thank you so much, Anissa. This is great. This is a really wonderful opportunity. And I really look forward to talking to your group and everybody online. I've been here at the University of Florida for about 14 years. And one of my passions has been Parkinson disorders, and particularly the group of we call atypical Parkinson disorders. And I'm going to spend today to talk to you about a disorder called multiple system atrophy. And actually, we now have we are a designated center of excellence for multiple system atrophy through the Mission MSA group. And so we're trying to expand, and we do have some clinical trials, and I will talk a little bit about the research. I don't plan to take the whole hour. I'm going to give you some slides here that'll lead you through. And I'm just going to talk about these diseases, kind of tell you a little bit about Parkinson disorders and Parkinson's disease briefly, and sort of what is MSA and how it's related to Parkinson's disease and how it's not, how is it different? And try to discuss some of the difference between the two different disorders, how we diagnose this disease, some of the features and treatments. And I think what you'll find is there's a whole bunch of similarities. They do diverge pretty quickly, but there are a whole bunch of similarities and things that overlap with Parkinson's disease. So with that, I'm going to pull up my slides for you all. Let me share my screen. All right. So here we're going to start out with a deep dive into multiple system atrophy today. Okay. So first, I always sort of start with this slide just talking about Parkinson's syndromes, because for me, Parkinson's disease is not just one disorder. So Parkinson's disease is very common. It's the most common disease that we see, or degenerative brain disorder that we see in the United States. And it's really second only to Alzheimer's disease. It's the prevalence of Parkinson's disease worldwide is doubling, and it has doubled over the past 30 years or so. In the United States, we estimate there's probably over 1.2 or 1.25 million people who have Parkinson's disease alone. That said, of all the patients who come in our clinic, about 10% to 15% of patients present with something that mimics Parkinson's disease. And there are a number of different causes, and I'll talk about those very briefly, but disorders that are like Parkinson's, but sort of deviate, and we call those atypical Parkinson's. And they used to be called Parkinson's plus, and I'll explain kind of what that means. So on the right, I list sort of different features that we call Parkinsonism, and you may have heard that term before, or maybe a clinician might have said you have Parkinsonism. So what's that? That really is just a descriptive term, just like, fever is a descriptive term. It's not really a cause or a disorder necessarily. So Parkinsonism really refers to a constellation of symptoms, and I like to use the acronym TRAP. T standing for tremor, that we see is typically a tremor at rest, not with activity. Stiffness or rigidity, that's the R. lack of movement, or what we medically call akinesia, or slowed movement, or bradykinesia. So akinesia is sort of on one end of the spectrum and slowed movement on the other end of the spectrum. And then postural instability, or loss of the ability to keep yourself from falling if you get knocked over, okay? There are many other symptoms that fit this syndrome, but the big things are the things I've listed in kind of blue here, that you must have either slowed movement or a resting tremor for Parkinsonism to be diagnosed. Now, the big question for us clinicians and for you all is really, what's the disease? What is the cause of your symptoms? And so there it kind of goes, we kind of get into the potential pathology. So I like to say, like, I'm trying to guess what's going on in your brain. The brain remains kind of a black box, and we can't take it out. We don't do biopsies. We often wait till you're done with it, I say. But we think about kind of what is the pathologic process going on, and we know a lot about that. In Parkinson's disease and many of the Parkinson's, where we know that we lose what are called dopamine-producing cells in the area of the brain called the midbrain, or specifically the substantia nigra. And I have a picture here. Hope you can see my arrow here that I'm pointing, but on the right is a normal brain where you see pigmented dopamine cells. They look kind of black to brown, why it was called substantia nigra. And on the left, you can see a Parkinson's patient's. And this could be seen in many Parkinson's, not just Parkinson's disease, but this patient lacks many of those cells. So that's one of the first hallmarks that we see in Parkinson's disorders. The other disorder thing that we see in Parkinson's disease is these protein inclusions. That can only be seen under the microscope pathologically. We cannot detect these yet on brain scans, okay? I'll talk a little bit about some of the recent research, but on the right, you can see the brown neurons. These are stained, and they're these little bodies, like inclusions in the cells. Those are called Lewy bodies. In fact, this purple thing is also a Lewy body in a dopamine cell. Looks like a little cancerous growth in your cells, and it does disrupt the way the cell works, and we think leads to degeneration of brain cells or loss of brain cells over time. Now, there are many other diseases like Alzheimer's, MSA, I'm going to talk about quickly here, and other disorders that have different proteins that abnormally accumulate, aggregate, and form inclusions in brain cells and lead to brain pathology. And so it's a common feature of degenerative diseases, from Alzheimer's disease to Parkinson's disease, okay? And I'll talk briefly about that. For me, really, when I see patients, the big issue really is usually, and for patients too, is it, do I have Parkinson's disease or do I have something else? And then the questions that I ask myself are, do I see some red flags in the story you give me, your history? A couple things that kind of bring red flags for me are, is it rapidly progressive? Parkinson's disease is a disease of 20, 30 years or more. It's very slowly progressive. So if I see someone declining over the first 5 years and they have a lot of terrible symptoms and disability, that's a red flag. Early things like severe gait problems, or we call balance and walking problems, freezing within the first few years, prominent speech and swallow issues in the first few years, atypical tremor, maybe a tremor that's an action tremor, not a resting tremor that we see in Parkinson's. And then there's one last thing. There's this response to medication. And so one of the things we do in Parkinson's disorder is often try to replace dopamine. So remember, one of the key pathologic or the pathognomonic feature of the disease is loss of dopamine in the brain. So we try to replace it. And one of the drugs that we often use is something called levodopa. So Parkinson's disease patients usually respond pretty well. Not everybody, but the vast majority do respond pretty well. If you don't respond well, then that is something that should raise a flag to your neurologist, okay? Then there are, on the other side of this screen, are these atypical, we call the plus features. So those are the Parkinson's plus features. Supranuclear gaze has to do with eye movement problems, autonomic features, and I'm going to go over that, okay? Those are things that are part of the automatic nervous system, like control of blood pressure, urinary bowel function, okay? Early dementia, okay? So that's prominent. Behavioral issues, psychotic features, and then there's some other weird symptoms that we often see in sort of very rare atypical syndromes, things like we call myoclonic jerks or Alien-Lehan that we don't see. So these things are just clues that kind of tell me maybe we should do a little bit more of a deep dive, okay? So this is something I published a number of years ago, just looking at things I like. It's been really useful for a lot of folks, just to look at the basic overlap of disorders. So Parkinson's is on the top, but it overlaps different syndromes. So there are symptomatic causes of Parkinson's like stroke, okay? Call that vascular Parkinson's, can cause that. Infections used to be like the flu, many decades ago, used to cause what's called encephalitis, Parkinsonism. So toxins in the environment, drugs sometimes can mimic the symptoms, and something called normal pressure hydrocephalus or NPH can mimic. There are also genetic hereditary causes that we look for that sometimes can have symptoms that mimic. And then lastly, kind of these atypical syndromes. I think of the atypical Parkinson syndromes as primary Parkinson's and not secondary ones, because they are degenerative and they are their entity on their own, okay? And they do have brain pathologies. And so another way I can organize these in my mind is to think about the brain pathologies. So the different proteins that are accumulated in the brain and cause pathology. So in Parkinson's disease, and I'm going to talk about MSA or multisystem atrophy today, are all we call synuclein pathology disorders. They are different a little bit. There's a group of tau disorders that includes Alzheimer's, okay? And there's amyloid, which kind of overlaps. So tau and amyloid go on, and Alzheimer's. And then there's something called the tau DNA binding protein, which is called TDP-43, that many people, that may be a new protein that you have heard, but that's related to ALS or Lou Gehrig's, as well as some frontotemporal dementia disorders. So a lot of things we've learned pathologically when we look at patients' brains. So it's an important thing for us to understand this. And then the reason why this is sort of important is that the future is targeting these pathologic processes to maybe modify the disease, slow it down, and possibly even cure it, okay? So that's where the future lies. So let me focus today on what's called multiple system atrophy. And I think you'll see how it fits into what I just mentioned, okay? So multiple system atrophy is one of the most common atypical Parkinson's, or it's sort of this, I call it the second, there's another one called progressive supranuclear palsy, but it's pretty common. They're both kind of neck and neck, essentially, okay? And it has a couple of faces or ways that it presents in our clinics, and that's on the right-hand side here. So one way it presents is it looks very much like Parkinson's disease, okay? So it has predominant Parkinson features like the tremor, the stiffness, the slowness of movement, okay? Another way that it presents is this we call cerebellar ataxia. So what does that mean? Ataxia is a term we use for incoordination, okay? So these are people who have problems with, they're clumsy, drop things, they have coordination problems, they have significant balance problems, and, in a sense, their speech and their gait are somewhat similar to someone who might look like they're drunk, okay? So think of that kind of presentation. It's very different than Parkinsonism. There is definitely overlap. One key feature that links these diseases is the presence on top of all of that of fairly prominent autonomic dysfunction. So again, when I talk about that, these are functions of the nervous system that you don't have to think about, okay? Your brain does these automatically. That's like control of your blood pressure, control of your bowel and bladder function, sexual function, sweating, temperature regulation. Okay, there are nerves and there are parts of the nervous system that control that. And these are affected in this disorder more so than in Parkinson's disease. And when you put them all together, that certainly raises the suspicion for this disease. So multiple system atrophy, while a common atypical syndrome occurs approximately like 3 out of 100,000 patients. So we're talking about roughly 20,000 patients compared to the over the million patients with Parkinson's disease. So it's a relatively rare disease that we see. The incidence is a little lower than that. This is a sporadic adult onset disorder with a mean onset or median onset close to the age of 60. So it's a little bit earlier onset on average than Parkinson's. But keep in mind, Parkinson's disease can begin before the age of 30, and we even see patients way into their 80s and even 90s, who develops Parkinson-like symptoms, okay? So this is a little bit earlier, but it's a gradually progressive disease, but more rapidly than Parkinson's disease, causing significant disability. So you may ask, what's the cause of this disease compared to Parkinson's disease? Well, we're still trying to understand that, okay? But pathologically, we've learned a lot in the past. This disease has been called by different names. The Parkinson type has been called something called Shy-Draker, even striatal language degeneration. The ataxic form was used to be called olivopontocerebellar atrophy because of the brain areas that are predominantly affected. And I'll show you that shortly in a picture. What linked them together was looking at the brains. Pathologically, what we see is accumulation of that protein called alpha-synuclein in Lewy body-like pathology. The catch is that these conclusions, now they're stained here on the left and with a brown stain, okay, aren't really located in nerve cells. They're actually located in supporting cells called glia. Glia are important because glia actually support your nerve cells. And in some cases, they actually produce what's called myelin, sort of the insulation that covers the nerve sheath. You can think of like the insulation on wires on the telephone poles. Without that, you don't have fast transmission of your telephone or your cable signals, okay? So the same thing occurs in your brain. You have these glial cells that produce myelin, support those cells, and they make the communication between nerve cells much faster, okay? So they're really important. But the key thing that was found pathologically among all these different presentations, they look like different disorders and the same pathology, and they are all linked together by what's called these glial cytoplasmic inclusions that you see here in this picture pathologically. So we think they're all similar. It's just that patients present a little bit differently, typically in two different type of, we call phenotypes, either cerebellar ataxia or predominant Parkinson's. So I'm going to talk about each one of them in a little bit more detail, okay? Clinically, there's a lot of overlap among Parkinson's disease and Lewy body, okay? Dementia, they all have synuclein pathology. The little difference is the nerves. So I talked a little bit about the glial versus nerves. This is the nerve cell you saw before. And then there are even some symptom overlap. So both Parkinson's and MSA have Parkinson features. Both of them actually have sometimes some autonomic issues. Sometimes you have some dementia, more so in what's called Lewy body dementia. So a lot of overlapping pathology and symptoms. I'm going to go into each one a little bit more detail, but I just wanted to just highlight a little bit of the overlap and then some of the difference. And I'm going to talk about those differences. So let me first talk about Parkinson's disease and how we differentiate what's called MSA Parkinsonism from Parkinson's disease, okay? So kind of weigh the symptoms here. So both disorders are this gradually progressive Parkinson disorder, okay? So where they differ is in the speed of progression, okay? So for MSA, the symptoms are on steroids. They really progress pretty rapidly, okay? When I talk about rapidly, you know, I mentioned that Parkinson patients have, you know, they live often for 20, 30 years or more with their disease. With MSA, often the average lifespan is roughly 6 to 10 years, sometimes more, okay? But it can be fairly rapidly progressive, causing significant disability. So rapid progression within the first years is certainly a clue. I mentioned the response to levodopa. Patients do respond, but not quite as well. And they can have some side effects from treatment often. That includes things like facial dyskinesias. So dyskinesias are abnormal, you know, abnormal involuntary movements that we see. Typically, you think about the dance-like movements you see Parkinson patients do. They kind of either head bobbing or swaying, or they have significant body movements, okay? In the case of MSA, you can still see that, but sometimes people have more prominent facial abnormal movements, and so even facial kind of, we call this dystonia or kind of grimaces. So that can happen in this disease. I mentioned early gait issues, early speech and swallow issues. The speech is actually a little bit different than what we hear in Parkinson's and can be a little bit more strained and slurred in these patients. The tremor itself, while sometimes it looks just like Parkinson's, can have an atypical look to it. It can be more mixed, look like an action tremor as well as a tremor at rest. And the tremor can be a bit jerky, okay? So when I look at a tremor, that abnormality is something that we pick up frequently. You can have what's called hyperreflexia or pyramidal signs. These are things that your doctor will look for on exam. And there are other things that we can see. Abnormal posturing. So although these can be seen in Parkinson's, they're more frequent in MSA. So posturing like a tilt of your trunk or even a tilt to the side, we call like a Pisa syndrome. Think of the Leaning Tower of Pisa, kind of tilting over by a trunk, not due to skeletal issues like scoliosis, okay, that we can see. There are a bunch of other symptoms that are associated with this disorder. See, we call a multiple system kind of disorder, hence the multi-system atrophy. So there are other things like disordered breathing, like sleep apnea. Patients often have things like restless legs sometimes. Sleep disorders like REM sleep disorders, that's dream enactment. Stridor, that's typically where they're gasping for breath, like really strong gasping of breath that can be quite dangerous and lead to significant discomfort and sometimes requires even a tracheostomy in patients. So a lot of different features. Lastly, I want to mention the autonomic symptoms. So while they're in Parkinson's disease as well, and I think many of those who've got Parkinson's, people often do have blood pressure or urinary issues. They just are more frequent and more prominent in this disease. So I list that maybe 5–10% of patients with Parkinson's here, nearly 70% of patients with MSA suffer from these disease issues, okay? Now, what about the cerebellar ataxic disorder, okay? So onset is similar, but a little bit more variable. It may be similar to what are called genetic forms of ataxia, and there are many forms of genetic ataxia that overlap. There's also even autoimmune or other causes of ataxia, which is that coordination issue. So these patients have predominant cerebellar features, okay? So they either have gait or limb ataxia or coordination problems, slurred speech, like that drunk slurred speech, or even abnormal eye movements. They may have some other symptoms. Some people have overlapping with Parkinson's. Again, they have what we call autonomic symptoms. They may have more mood issues like depression, anxiety, and even a little bit of progressive dementia as well. Okay, so I'm just listing some of the features to get you highlights. I realize there's a lot on these slides, but I want to make sure you get the overview. Okay, I'm going to talk a bit more and I'm going to cover some of the different features. So how do we diagnose this condition? For us as clinicians, there have been lots of different diagnostic criteria. So we use diagnostic criteria to help us. Over the years, there have been a number of published, and there's even been studies showing that, well, we weren't doing so good. So we were accurate about 60 to 70% of the time. And there are things that look like MSA. So on the right, I show you some of the examples. So things that look like MSA are Parkinson's disease, other atypical disorders. Sometimes MS can look like Parkinson's or even MSA. There are other ataxias, okay? And then there's something called autonomic failure. So patients who have a lot of autonomic issues, blood pressure, bowel or bladder issues, but they don't have Parkinson's yet, they may convert to multiple system if they develop Parkinson features. But there is a disorder we call just pure autonomic failure, okay? I think the bottom line is we weren't doing very good, right? So there was a task force that was started by the Movement Disorder Society, actually, on MSAs that was started back in 2018. And recently there have been new diagnostic criteria published. All right, busy slide, but I think I'm just going to point out, this is really for us, but I think the point is there are a number of things shown on the slide that we have a couple of different ways. So there are prodromal, or we call possible disease diagnosis, versus we call probable or clinically evident now. The main thing really to see is that you need to either have presence of Parkinson disorder or cerebellar syndrome plus autonomic dysfunction. And there are a lot of different symptoms. And I'm going to go through each one of them a little bit for you. Okay, but we do have new diagnostic criteria that are going to hopefully help increase our sensitivity and ability to diagnose this disorder. So I'm going to break this up. All right, so let's take a little bit apart. Okay, that's a busy slide. So core features for disease for multiple system atrophy, either a progressive Parkinson's disorder, including stiffness or rigidity, plus or minus a tremor, or a cerebellar syndrome. So those two we call phenotypes, two ways it might present. If it's a cerebellar syndrome, you need to have either balance or limb ataxia or slurred speech or eye movement findings, okay? Plus the presence of autonomic problems, either orthostatic hypotension, which is drops in blood pressure upon standing, or urinary problems, okay? In this particular diagnostic criteria, you need to have things like urinary urgency with incontinence. And there is something we call a post-void residual. So patients sometimes do experience problems emptying their bladder. And urologist or even your doctor's office can actually measure how much urine is left in your bladder after you urinate. So not completely emptying your bladder, having over 100 milliliters of urine still left in your bladder after you empty it, can lead to a feeling of sort of incomplete urination. And that's something that we can actually measure. Okay. There are many other symptoms that are listed here, and I'm going to discuss some of them. So let's talk a little bit about urination. And I know these symptoms are also common in just Parkinson's disease. Okay. Urinary symptoms are really common. They occur in nearly 20% of patients as the sole initial symptom, okay? And they can occur prior to the onset of symptoms, okay? They're really common in Parkinson's and sporadic adult onset ataxia disorders too. First thing we have to kind of rule out is other causes, like structural causes in men, prostatic hypertrophy, sort of enlarged prostate, that can cause urinary problems. History of prostate cancer, okay, can cause urinary problems, okay? So what are we looking for? Either too much output, like overactivity, or difficulty urinating. So when we talk about overactivity, that's going frequently, maybe getting up, 4, 5, 6 times a night to go to the bathroom, and even what's called urge incontinence, not making it, either sneezing or not making it to the bathroom and having some leakage. We're talking frank urination, okay? Voiding difficulty is a little more complicated. This includes things like I just hesitate, I can't go. Maybe an intermittent stream or poor flow of urine. And then that sensation that I sat on the toilet, but I'm not done, and I have to go back 5 minutes later to go again. Okay, and those are things that we can look at and measure, and the urologist, again, or your primary care office sometimes can actually evaluate that. So there's two sides of the coin here a little bit in terms of urinary issues. In men, there's another feature we talk about that's erectile dysfunction, and if it's early onset, and what they picked was 60 years, okay? That's usually when erectile function changes a little bit, and it progressively worsens over time, okay? But if it's really early onset, that can also be kind of a clue in men. All right, well, let's talk a little bit about some of the autonomic symptoms, and let's touch base on the blood pressure. We call it a cardiovascular symptom here. So what is this thing I call orthostatic hypotension? So it sounds like a complicated term, but orthostatic just means changes in position, okay? So if you get lightheaded when you sit up from your bed or you stand up from a chair, okay, and you get that lightheaded or dizzy feeling, okay, that may be because your blood pressure is dropping. Doesn't necessarily mean you have orthostatic hypotension, especially if you compensate. Okay, so for most individuals, you rapidly compensate. So your blood vessels squeeze and your heart pumps more quickly to maintain blood pressure and perfusion of your brain, so you don't feel that way. Okay, so there is a definition here, and the way we measure orthostatic hypotension is by having somebody sit, take their blood pressure, and then have them stand for 3 minutes. Okay, there's importance. We don't really care about the immediate drop because it does usually compensate. What we care about is whether it's a sustained low, okay, that will make you feel lightheaded and can impair your activities, okay? You may feel like you have to sit back down or lie back down. So orthostatic hypotension is technically now defined by a drop in blood pressure. The top number is called systolic, the bottom number is called diastolic, So it's defined by a 20-point drop in the top number and 10-point drop in the lower number within 3 minutes of standing, okay? Typically, our heart rate goes up, and there is a number that's sort of about a half a point per blood pressure drop, okay? So it should go up, but if it doesn't go up, that means your heart isn't compensating. So that's even worse in the sense of that's telling us that there's more autonomic issues, because normally that's what happens, okay? That's supposed to happen. Now, there are definitely lots of different causes. It doesn't have to be MSA, okay? So if your hypovolemia means you got low blood volume, so what I like to talk about is the tank. If your tank is empty, okay, meaning you're dehydrated, okay, your blood pressure is going to be low, okay? So we always, all of us docs harp on stay hydrated, okay? Blood loss can cause that. Drugs can cause drops in blood pressure. Anybody who's on antihypertensives, there are lots of other medications that can drop the blood pressure too. So over-treatment sometimes or inappropriate drugs can cause the blood pressure drop. There are lots of cardiac causes. So if your heart isn't working right, you have heart failure, rhythm problems, valvular disease like aortic stenosis. Some people have venous problems, okay, swelling in their legs. Neuropathies can cause this, even diabetes can cause this. And then there could be even spinal injuries or central injuries. So a lot of things can contribute to this, okay? So just having orthostatic hypotension doesn't mean you have neurogenic orthostatic hypertension or MSA. I mean, actually, the sensitivity is not that high. Specificity is actually higher than the sensitivity of this, but it is one thing that we do test, okay, for autonomic dysfunction. I know there are lots of other symptoms that are involved, so like bowel problems, like constipation issues, gastroparesis, temperature dysregulation, sweating, can all be part of this, okay? It's really interesting that patients often do present early on with problems to their primary care doctor, and talk about problems with blood pressure or bowel or urinary issues. And those symptoms may predate years ahead of the onset of Parkinson's or MSA. In fact, about 75% of patients do present several years, at least 4 years before. So in men, that might be erectile failure early on or voiding difficulty, okay? In women, that might be reduced genital sensitivity. In terms of blood pressure issues, you may have symptoms really early on. It's often the first symptom you have during the first year of disease, okay? And it actually very well predicts MSA in some cases, okay? Feeling lightheaded is not the only symptom you can have if you have orthostatic hypotension. You can feel like you have sort of this weight on your shoulder. We call that a coat hanger syndrome, like on your neck or your shoulder. You may feel tired or fatigued all the time, or even confused when your blood pressure is low as well, okay? There are other symptoms that may predate the onset of symptoms like breathing issues. So this stridor, sleep apnea sometimes precedes symptoms. One symptom that a lot of Parkinson patients seem to have is what's called dream enactment when you dream, that's what's called rapid eye movement or REM sleep, okay? It's an early part of sleep, okay, that people have. And your eyes are supposed to be moving, but your body should be flaccid and not moving. So individuals who, when they're dreaming, actually act out, punch, kick, yell out, scream, if you ever punched your partner or even fall out of bed, that's what we call REM sleep behavior. It's not really normal. It can be present as we call a prodromal symptom in Parkinson's, but it's actually much more frequent in dementia Lewy body and multiple system atrophy. So it's very common. Up to 90% of patients have a history of this. It often occurs either before, during, and then sometimes burns out during the latter parts of the disease, okay? And it does predict a degenerative disorder, okay? The other one that you may have heard about is this problems with your nose and smelling things in Parkinson's disease. That's what we call hyposmia. Very common in Parkinson's disease and actually one of the predictors for Parkinson's, but not specific. We see that also in other degenerative diseases like Alzheimer's disease. Less common in MSA. Okay, so just wanted to point that out. All right. So I talked about some of the symptoms. I do want to go into a little bit about some of the tests that we do. It's going to get a little bit detailed, but For blood pressure, it's simple things we do, just test blood pressure at the bedside in the clinic. But we can do specialized tests like what's called a tilt table. So we can have you come into an autonomic lab, put you on a table that actually gradually tilts, and we can graph out the blood pressure and the heart rate response. That's called a tilt table test. Okay. So that's part of what's called autonomic testing. During those tests, often labs will also do what's called sweat testing. Okay, they put a little thing on your skin and they actually measure the amount of sweat that you produce. Your urologist as well as the gastroenterologist can do tests on urinary and bowel function as well. Right. For disordered sleep and breathing issues, we often recommend formal sleep studies, and sleep studies can detect things like sleep apnea and the need for potentially a CPAP. They can look for things like stridor. They can evaluate for dream enactment and restless leg symptoms during sleep. You may not know you're doing it, especially if you don't have a bed partner. Okay, and so these tests can formally help diagnose that. And then there's brain imaging, which is very commonly used. I'm sure all of you are familiar with either CAT scans or MRI. So I'm going to show you some images here. And I think imaging has really taken some large leaps forward helping us diagnose these diseases. For Parkinson's disease, we often don't see any major image changes, okay? There are some research studies that are out, and there are some research scans that are higher resolution that may show some changes. But largely, I think if you have the diagnosis of Parkinson's, what we're looking for are other causes. But in a patient who has what we call idiopathic Parkinson's disease, the brain scan is usually normal or age appropriate, okay? For multiple system atrophy, this is more progressive. We do see changes on brain scans that we look for. So as a neurologist, I'll do a brain scan and often look for changes in the part of the brain we call the basal ganglia that's affected by Parkinson's. And sometimes we can see degeneration and even some iron deposition, this sort of black stuff here. That's what it looks like on an MRI. And we can see that deposition. And sometimes we see some other changes that are found on different scans. Likewise, we look at sort of the side view of the brain sometimes. And remember, one of the disorders called MSA cerebellar used to be called olivopontocerebellar atrophy. So these are the areas we're talking about. This is actually a side view. This is your brain here, and this thing here is called the brain stem, and this little bulbous part's called the pons. So we're actually looking for this area of the brain to degenerating, so decrease in size of the pons and the cerebellum, okay, and patients who have ataxia or the ataxic form of MSA. In some cases, it's so bad that we can actually detect scarring, or we call gliosis of the brain. And one thing we look in the brainstem is for this hot cross bun sign. You can kind of see it on this image on the bottom corner here, okay? So there are some MRI findings. I just wanted to point out those. And there's advances on MRI imaging that do help us. They're not always perfect, but they definitely can help us with diagnosis. The other scan that you probably are familiar with is what's called the DAT scan, the dopamine transporter scan. So the DAT scan's been around for several years now. It was FDA approved early on to distinguish what's called essential tremor from Parkinson disorders. And I think the key is Parkinson disorders means plural. So it wasn't just essential tremor of Parkinson's disease. Actually, it's abnormal in almost all Parkinson disorders, including multiple system atrophy. So it still can be helpful in this disease to show it. So left is a normal person who has these two comma-shaped kind of pictures, and on the right side is an abnormal patient, okay? So we can use that, okay? So these are kind of available things currently for us. Now I'm going to kind of turn to some newer stuff that's available too as well that you might have heard about, okay? So I mentioned early on that beyond dopamine loss, there's these Lewy bodies, and they contain what are proteins called alpha-synuclein, both in Parkinson's and multiple system atrophy. So researchers have been working feverishly over the past decades, and they've been trying to find ways to detect these proteins outside the brain, either in spinal fluid or blood tests. It's been very difficult to do that. However, there have been some great strides in this recently. The Michael J. Fox Foundation, particularly in their what's called the PPMI study, recently had a big publication that reported that we could detect alpha-synuclein or the pathologic form in spinal fluid, and that could be a new biological marker for Parkinson disorders, okay? And so that's called a seed aggregation assay, or called a seed amplification assay is the other way to put it, or SSA. And what that involves really is just taking a little bit of your fluid, putting it in a test tube with a bunch of other protein and seeing how it aggregates over time. And you can graph it out. So on the left here is just a graph of a Parkinson patient. So over time, you see the rise of this little, of the amount of aggregation that's graphed out here. And you can see differences in Parkinson's from multiple system atrophy. So there are strides. This is still just starting to get out clinically available. It requires a spinal tap. I mean, most patients don't want to do that, but it's actually fairly easy to do. It can be done in a clinic. I think the other test that's out that you may be interested in is what's called this new skin biopsy that you might have heard about to help identify Parkinson disorders. So this is a test that was developed by PMD Life Sciences. It's called the SIN1 test, okay? So what does this involve? It involves 3 little tiny punch biopsies. They're 3 millimeters in size, so really, really tiny. But they're little punch biopsies, and they're done at the base of the neck and 2 in the leg. And we just send them off for testing, and they do some stains, okay? And they're looking for the presence of synuclein, pathologic synuclein in nerves within the skin. The really exciting thing really is that the presence of this is very common in Parkinson disorders, particularly disorders that have synuclein in them. Parkinson's disease, dementia with Lewy bodies, or DLB, multiple system atrophy, and even what's called pure autonomic failure, okay? The numbers are really pretty impressive. So for multiple system atrophy, the presence occurs, we can find abnormal biopsies in over 96% of patients. That's very high in terms of sensitivity and specificity in patients. So the negative predictive value is a little bit lower, but if there is present, if it is definitely present, it could support a diagnosis. And this is a really easy test. It takes 15 minutes to do the biopsies. It just takes a few weeks to get the results back, okay? And it is supported by insurance. There is a little bit of distribution differences between Parkinson's. This graph, or this picture on the right-hand bottom corner here, shows that in atypical Parkinson's disorders, the presence of abnormal pathologic alpha-synuclein in skin is much more widespread than that found in Parkinson's disease. Okay, so this is somewhat helpful to us, okay? And we have started to do this in our own clinic. So these are advances in disease. So let me turn to some of the treatment. I'll be really quick. I really believe that, at least at the Fixel Institute, that treatment requires a team and like a multidisciplinary team. This is a very complex disorder. I've only touched the surface of it. But at our center, we kind of put the patient and caregiver at the center, and we kind of bring the team around you. So that includes sort of core people like the therapists, myself, the nurses, the case manager, and then all the different specialists that you might need, okay? So this is really key and important, and that's what we do in our multidisciplinary clinic here. I will talk a little bit about treatment. There are lots of aspects, from the Parkinson's to the blood pressure, constipation, all this stuff. So let me just briefly talk about that. So there's a lot of detail on this slide, but I'll just talk about the fact for Parkinson's, number one, we almost always try levodopa first, okay? All right. So despite the fact that most patients eventually fail or they have a poor response, it's still worth trying. So I've listed some numbers here. Yes, the medication can have side effects that we watch about, like can lower blood pressure, exacerbate blood pressure problems. You can have what are called dyskinesias, okay? Other dopamine drugs like dopamine agonists, they might be beneficial, but they're more likely to worsen symptoms. We don't use them. You might have heard of what are called MAO inhibitors like selegiline and rasagiline, but they haven't really been tested in large groups, and we don't find a lot of benefit for them. Other drugs like amantadine and riluzole, these are off-label uses, have been tried, but only in very small groups with limited benefit and often failure. So levodopa remains our best drug for Parkinson's. So I just want to get that out there. A lot of people ask me, how do you treat ataxia? Well, with difficulty. So mainly it's supportive. We unfortunately don't really have good drugs to treat coordination problems and balance issues. So lots of things have been tried. I list a whole bunch of these. Probably the newer ones is called 4-aminopyridine, or what's called dalfampuride, or there are different names for this have been tried. They don't really work that well. We may try them in clinic. It's definitely something to discuss, but in general, I've had some poor responses with MSA. And so I'm going to talk a little bit more. I can briefly talk about blood pressure issues. There are lots of different drugs to try for blood pressures to raise the blood pressure. Okay, you may have heard of some of these. One drug, fludrocortisone, actually acts on the kidney and it actually increases blood volume. All the rest of them are just to increase the blood pressure, okay, like mitogen and droxidopa, which is also called Northera. For GI, we have lots of different suggestions. Sometimes I just refer patients to a specialist. There are things that we can use to treat constipation, from stool softeners to laxatives. For urinary issues, there are many options, okay, for bladder therapies. If you have overactive bladder, we usually use antispasmodics. Some of the early ones do cause side effects. There are newer ones out, like mirabegron, that have lower side effects, but they're much more expensive. If you have urinary retention, unfortunately, there are really no drugs that help with that. Often patients need to catheterize themselves, either intermittently or actually place a catheter to treat that. And that's something to discuss with a urologist. Okay. I'm going to skip this briefly because that's a little more complicated. What I want to talk about and emphasize really is that patients need to have supportive care. So medications only play half the battle in these patients. Working with the team, therapists, physical, occupational, and speech are really important. Speech swallow problems are more prominent. And so getting regular, swallow tests and seeing speech therapists can be really helpful. Having a nurse available, a nurse aide for additional care, and then social services. So that's bringing the team together for every patient. One other thing I always just mention really is, we have to think about these diseases. There's life and then there's death. So thinking about how to end your life gracefully is really always important. So ask your caregiver about it. Early on is a good idea. Palliative care is not just hospice, so just list that out there. It's really a focus on comfort. Sometimes we think about it as focusing more on quality than quantity of life, and ending life under your own means, okay? So there's a lot here to talk about, okay, but it doesn't mean losing your doctor, and we can play a role in this, okay, in helping patients. I do want to mention trials. There's lots, and I'd have to take another hour to talk about different trials for this disease. But I list a whole bunch of stuff and ways to tackle it. There are new symptomatic therapies that are being tried. There's drugs for Parkinson's. There's drugs for the ataxia that are being tried. There's new drugs for the blood pressure that are being tried. The last one, called ampreloxetine, is actually under trial currently. It's a new blood pressure pill. It's actually a stimulant type drug that's being tried in patients. On the right, all the white clear boxes are what are called disease modifying things. And there are lots of ways to attack this disease, like, do we protect the nerve cells? We call them neuroprotective things. And there are a number of things that have been tried in trials. A few have shown no benefit already. I list some of them. AV, like viral stuff like GNF, are still being worked on. Extenditide is another medicine that's out, but not for this disease. That's being tried also with Parkinson's. Reducing inflammation. A number of things have been tried. Cell therapies are still out there. We don't do stem cells for Parkinson's, but stem cells have been tried in MSA. If you're interested in that, Mayo Clinic is doing a study, and patients have gone there. They're not widely advertising or widely enrolling patients, but they are doing a study. And there have been some interesting reports from Korea showing some potential benefit, but there are some risks there. Where a lot of the studies are at are here on the other side, targeting these abnormal proteins like alpha-synuclein. I will point out there are a few that have failed. The immunotherapy trials are still ongoing, okay? A couple ongoing studies are this Amulet study. They're going to have a phase 3. The phase 2 is closed, okay? This is an antibody trial where they infuse a drug monthly. TAC is another study that was ongoing, but I believe is closed. Ono Pharmaceutical is testing a drug also that targets alpha-synuclein, reducing its spread, and that is definitely enrolling. Alterity was a small molecule targeting iron and aggregation of synuclein. They recently published their phase 2 results online, and it looked really promising. So phase 2 trials are small, and usually you need to go to a large trial called phase 3 trial before it gets approved by the FDA. So phase 3 trials typically are much larger, involving hundreds of patients, and they're designed to look for a disease effect and safety. Okay, so trials kind of go, in order. So phase 1 usually is just for safety, testing a drug out. Phase 2 are usually we have a smaller group of patients that we're testing tolerability and whether there's a hint of something going on. And then a phase 3 trial is a larger trial. It's usually before it goes to the market. Okay, so this is just a phase 2 trial. Some of these drugs will go to phase 3. They may or may not continue to show benefit, but they're really important, and it's really important to get patients involved. Without patients, none of these trials are really possible. Okay, so I wanted to give you kind of an impression, and the really neat thing for me is that, there used to be like 1 or 2 companies, and now there's like the host of companies. And the companies are where the funds and the monies are, who can really afford doing these multi-center, really big trials. And when you think of a rare disease, you need to work together. So our clinic alone can't do a study like this. We have to work with many other centers throughout the United States, and even sometimes internationally, to do studies on these rare diseases. Okay, so listen, I'm going to stop. A lot of stuff. MSA is like Parkinson's, but it has varied presentations that overlap. There are new criteria that's going to help us with sensitivity and with diagnosis. There are early symptoms that maybe help us predict this disease. There are new tests, not just MRI, but skin biopsies, maybe even fluid tests. There are symptomatic treatments. It does take a team, it takes a village, I think, a team approach. So I would seek out specialized clinic like ours. And there are new experimental treatments and therapeutics that are being developed all the time now. It's an exciting time to be in the field and to work with patients. This is a rare disease, and so, difficult to get companies, but people are really interested, and we hope if we can crack one of these diseases, maybe we can crack even Parkinson's or Alzheimer's. So I'll stop there and see if you guys have questions. This is our big group here. It's only part, that's not everybody. That's our clinic and our part of our group and our team. So big village. So thank you very much for listening. I know there were questions, so.
Yes, thank you so
I'm
much.
going to get out of this.
I'm going to kick off with one of the questions. I know you mentioned temperature dysregulation, but this person wanted to know if you could spend some time on the loss of internal thermostat. So chills, heat, sweating, that variability. My husband has been diagnosed with MSA, but his main symptom is temperature control, and it impacts his life so much.
Yeah, I can talk about it. There are parts of the brain that help control your temperature, usually the middle of the brain. And temperature control is a really big deal. A lot of patients complain like I'm either hot or cold. They may have sweats, often night sweats, or even sweats during the daytime. There are other reasons to do that, like there are hormonal issues that patients get screened for, like thyroid issues that might impact that. Change in the body hormones can do that. But if those have all been screened as, it may be your MSA. It can be really horrible, those drenching night sweats or temperature changes. They're difficult to treat. There really are no great medications to treat. I guess I don't spend a lot of time on it because there really isn't much data and information on how to treat this temperature. We don't have great medications. Sometimes we look at the current medications you're taking and review them. So a review of your current medications, particularly your Parkinson medications, because those can have effect if you're wearing off. Sometimes patients get anxious, they have night sweats, and that can contribute. Sometimes you're not getting enough medication. So I've seen varied reasons for having symptoms. Sometimes other medications could be a cause. Maybe things like blood pressure pills could be a cause for that. So looking at all the medications can be important. Occasionally we do use some medications like clonidine or other things that can help, but I have to tell you that it's sort of hit or miss a little bit on treating these temperature dysregulation.
We also had a question about behavior, and you mentioned it at the beginning, I think, of your presentation. But can you explain a little bit about some of the emotionality or the outbursts that people might see, some of the behaviors, cognitive, emotional?
Yeah, I definitely can talk about the behavior changes. So behavior or mood changes can occur in all these disorders. Multiple system atrophy and other atypical Parkinson's disorders have much broader or widespread brain pathology. And so they can affect the frontal lobes and other areas of the brain more so than maybe just standard Parkinson's disease. So with multiple system atrophy and even other atypical Parkinson's, we see a higher prevalence or frequency of mood disorders like depression, anxiety. Sometimes we call it labile mood, and even what becomes what's called pseudobulbar affect, or when patients either laugh or cry inappropriately. So they can't control it. They're inconsolable sometimes. The laughing may be inappropriate. That's what we call pseudobulbar affect. And we sometimes see that in both MSA and other atypical Parkinson's, rarely in Parkinson's disease itself, but there are treatments for this. If there are behavioral outbursts, that's a little unusual for MSA. Sometimes we see that in dementia. However, behavioral outbursts like anger, agitation, and those need to be treated differently. Okay. I would also say that drugs are not always the solution. Thinking about what are the triggers, really closely thinking about that in patients who can't talk or they have dementia. Simple things like temperature in the room, being hungry and not being able to communicate that can lead to behavioral outbursts. Okay.
And related to the temperature control, can acupuncture help? Does it serve any purpose for MSA symptoms?
I'm gonna say I don't know the answer to that question. I'll have to get back to you. I have referred folks for acupuncture, but I think talking with acupuncturists, if they're really good, I think some people probably do get some success, but I'm not familiar with acupuncture. I'm not an expert in that, so I can't really speak to that.
So I know you talked a little bit about the orthostatic hypotension. When someone's blood pressure drops over 100 points, do you have any recommendations? And it can be, maybe even non-pharmacological things that might be beneficial.
Yeah, blood pressure is complicated, I think. So I also work with a cardiologist, and we kind of both have similar things that we tell patients. So behavioral modification is sort of the first things that we try to attack for blood pressure. So number one, staying hydrated, thinking about what are the triggers. So getting up really quickly, bending over a lot, and standing up that can cause blood pressure changes and make you really dizzy. So avoiding those kinds of things. We're in Florida, so the heat and the humidity. So trying to stay out of that. Make sure you're wearing a hat. So those things are just behavioral modifications, can change things. Likewise, if you have lows and highs, sometimes just considering, sitting, laying down if you're having low blood pressure versus if your blood pressure runs high, stand up for a while. With folks who have, blood pressure regulation, it may drop and they may help lower it if it's really high. Sometimes people have what's called supine hypertension. That's hypertension when they lay down. And that can affect the sleep, affect going to the dentist office or laying you back and your blood pressures are 200 over 100 and they stop the procedure. So that may sometimes need to be treated. And we often do recommend for dysregulation is to raise the head of bed up. Okay. So a lot of different behavioral modifications you can do. Just know that blood pressure does change a lot with activity, stress, anxiety. It's going to shoot your blood pressure a bit up. Okay. Very common coming to the office, doctors, white coat syndrome, having higher blood pressure when you're stressed. So thinking about kind of what triggers things as well. And there are lots of medications that sometimes that we turn to treat blood pressure. And one thing often that comes up in our clinic is when to give those medications. So often patients are prescribed medicines and they're told to take them in the day, also the night, and they're kind of mixed up and they're treating both sides of the candle, basically, the highs and the lows. And it's hard to do that. And sometimes it's a matter of timing, taking medicines to increase the blood pressure in the morning when they're active during the day, and then medications that lower the blood pressure at night when they have highs. Okay, laying down. Okay.
So I know we're out of time, but one last question that I think will cap this off well is, should someone with MSA see their movement disorder specialist more frequently than maybe someone with Parkinson's?
I would say yes. Parkinson's is much more slowly progressive. We usually do recommend a couple times a year. With MSA, I think patients sometimes have to come in more frequently and utilize our other services, seeing therapists, having different evaluations, swallow valves, and that may include actually meeting with other care providers. In our clinic, we have a GI specialist who works on motility. So for patients that have really difficult issues with bowels and control, seeing a specialist, and we do that in our clinic. That may involve also seeing like a urologist or a sleep specialist. So bringing in specialists too are really important. Psychiatrists if there are mood issues too. So I would expect having more frequent visits with your doc and your neurologist. And it's important to have like a specialist. It's a complicated disease, and I think having that team of people around you, or at least having a link to a specialty care provider like our center, can really make all the difference.
Well, I want to thank you so much, Dr. McFarland, for giving this deep dive. It was very informative, and I'm excited to see these clinical trials that are happening. Gives a lot of hope that there may be some really effective treatments out there in the future. And for all of you who are interested in finding out more about clinical trials, I know we've given you the link before, but if you go to clinicaltrials.gov, you can search for a variety of different clinical trials that are in different phases. So we always encourage people to engage in research to the degree that they can. So thank you, Dr. McFarland, for this.
Thank you all. Thank you so much for inviting me to do this.
Awesome. And I will invite everybody to give you a send off with the wave of gratitude and appreciation for this wonderful information. And thank you everyone for joining us. Again, if you want to share this or if you want to go back and watch it, it will be available in a couple of days online. So thank you so much. Take care.
Bye-bye.